Thank you. Thank you to SAGES and the session organizers for inviting me to speak today on one of my favorite topics. There we go. Oh, then it went back. Okay, I have no disclosures besides I'm wearing my net-themed jacket. The questions I will attempt to answer today is, when is surgery indicated for pancreatic neuroendocrine metastases, and what is the role of hepatic cytoreduction and synchronous resection of your pancreatic neuroendocrine tumor? The key word in that slide was that I will attempt to answer them. I'm not sure I will actually be able to give you an answer. As you've heard from my esteemed colleagues thus far, metastatic disease is common in all types of gastroenteropancreatic nets, with pancreatic primaries metastasizing to the liver in up to 40 to 60% of patients, of whom about 20 to 30% are typically resectable. There are multiple treatment lines available for patients with net liver metastases. I like to break them up into two categories, typically systemic therapies with cytostatic and cytotoxic agents, and PRT, and then liver-directed therapies, and I consider surgery as one of the liver-directed type therapies when we're talking about surgical debulking and ablation. We've already heard about hepatic arterial therapies from Dr. Solin and radiation therapy, which is infrequently used. So, when seeing a patient with a neuroendocrine tumor liver metastases, what are the next steps? Typically, the question I like to ask myself is the disease localized to the liver? And if that answer is yes, then the second question, I believe, is there a low tumor burden in the liver, or is there a heavy tumor burden in the liver? If the tumor burden in the liver is low, then I think those patients are typically more favorable for surgery. It doesn't necessarily mean that it's your first line of therapy, and you can consider systemic therapy in concert with surgery or in sequence to surgery, but certainly lower tumor burden are patients who are eligible for surgical resection. If the tumor burden in the liver is heavy, typically surgery is not the mainstay of therapy there. We would consider liver-directed therapies and systemic therapies, and certainly PRT, and I think we alluded to the concept of neoadjuvant PRT, which I think all of us are exploring independently, and there hopefully will be a trial soon coming out of a few of the different groups, including Alliance, to see what the role of neoadjuvant PRT might be. If the disease is not localized to the liver, then the question is there heavy, widespread tumor burden outside the liver? In those scenarios where there isn't, you can certainly still consider liver-directed therapies. Patients may be amenable to surgery down the line, but again, you would prefer to know if you have some disease control initially if you have extrahepatic disease. Why consider surgery for neuroendocrine tumor liver metastases? Well, there's a number of retrospective studies, and that's the limitation we have in studying this disease type. We don't have a ton of prospective randomized studies comparing different types of therapies, and so everything we speak about is based on retrospective studies, which certainly have selective selection bias. These are a number of studies, mostly small numbers, in whom patients with liver metastases from primary small bowel and pancreatic neuroendocrine tumors underwent cytoreduction of their liver disease, and 5-year survival rates were anywhere between 60 and 80%. The question is, would those survival rates be just as good if they were never touched by a surgeon? And that is a question that I don't have an answer to. When patients come to you and say, hey, I've heard that surgery is better than ablative therapies to the liver, there's papers like this that have been published that say, sure, patients who had curative cytoreduction or palliative cytoreduction better than those patients who had embolization. But the key there is that you have to look at the patients that ultimately went to cytoreduction versus embolization. The patients that Dr. Solin is seeing have essentially extensive disease throughout the liver and probably would not be amenable to a sufficient debulking procedure, where those patients who are going to surgery likely have better biology of disease and more favorable recurrence within the liver should they develop it. In terms of tumor debulking and criteria for tumor debulking, this is the image here is not representative of what I'm about to say, but it was first published in 2013 by Sarmiento and his group from Emory, essentially that a 90% debulking was as good as a complete debulking. A majority of those patients actually had functional tumors, and we know that functional tumors basically behave better when debulked. This was another study out of the University of Iowa where they performed 188 hepatic cytoreductions. Most of these patients had primary small bowel neuroendocrine tumors, and I just don't need to tell this audience, but in case you forget, small bowel neuroendocrine tumors and pancreatic neuroendocrine tumors are not the same. So I think you have to digest all of this data with a little bit of understanding of the underlying disease biology. But in this particular study, they found that overall survival really was no different if you could perform a 70% versus 90% debulking, and the progression-free survival tended to be better if you could debulk more disease, which is not necessarily surprising. So these are the main studies from which we derive our debulking thresholds. I think the bottom line, and what I tell my patients, is regardless of the debulking threshold and whether I completely debulk you, get to 70% or 90%, your recurrence rate is practically 100%. So this procedure is largely palliative, and it really depends on specific selection and other therapies that we may have available for those patients. Because they have high recurrence rates and the procedure is palliative, you certainly have to consider the approach to surgical resection, and there's many ways to skin a cat. You can see here, this is a surgical audience, so there's many ways essentially to deal with metastases depending on where they're located, and because we prefer to spare liver and perform parenchymal sparing surgeries, we typically like to do what Dr. Warner refers to as wedges on the edges and then ablative therapy so that you could preserve as much liver function for future additional therapies for when they do recur. This is one such patient in whom we removed 14 neuroendocrine tumor liver metastases. They could be enucleated. We ablated 4, and we simultaneously removed a distal pancreatic net that was encroaching into the splenic hilum and giving the patient symptoms, and they did fine. They will recur. They haven't yet. And of course, you could do this in a minimally invasive approach if you feel that you can do it. What about synchronous resection? So just to set the stage, this was a study that was multi-institutional. All PNETs were treated with curative intent. It included primary pancreatic neuroendocrine tumors in patients who had advanced pancreatic neuroendocrine tumors, which means they had liver metastases. And the pancreaticoduodenectomies and distal pancreatectomies were performed at the discretion of the surgeon. Some patients occasionally had enucleation when appropriate, and in patients who were treated with synchronous liver metastases, pancreatectomy was associated with 1 or 2-stage liver resection. I think what I want you to take away from this is essentially that there was no significant difference in terms of the subtype of patients. Most patients had distal body tumors, and most patients had non-functional tumors and underwent actual anatomic pancreatic resections. But the bottom line was those patients who had no metastatic disease at the time of presentation and had pancreatic resection did significantly better from an overall and disease-free survival standpoint, suggesting that those patients who are presenting with liver metastases, you need to take into consideration, again, if you're going to be taking these patients for surgery and debulking, the disease biology is a little bit different than just a standalone pancreatic net. This was another study that looked, I believe, at about 51 patients, looking specifically at simultaneous resection of pancreatic neuroendocrine tumors with liver resection. You could see a majority of the tumors were in the distal pancreas. A majority of patients had distal pancreatectomy, splenectomy with respect to their liver resections. A majority of patients had exclusive resection, and the second highest subset of 41% had resection and radiofrequency ablation. And mortality and morbidity were not terribly high. There was one mortality. Morbidity was 27%, and major morbidity of grade 3 or 4 was essentially 11%. When looking at univariate and multivariate analysis of risks of worse overall survival, on univariate analysis, older age, higher grade, and lymph node metastases were significant, but on multivariate analysis, only grade 3 tumors portended worse overall survival in this subset of patients, suggesting that in the appropriately selected patient, which I would argue should be a grade 1 or 2, simultaneous resection is feasible with acceptable morbidity and mortality. I don't know if morbidity is ever acceptable. I take that back. Mortality. I'm sorry, I don't know if mortality is ever acceptable. Morbidity. So this was another study from Memorial that looked at synchronous resection of primary and liver metastases. It included 36 patients, all of whom had grade 1 or 2 pancreatic neuroendocrine tumors that were treated between 1992 and 2009. And in these patients, they performed synchronous resection of the primary neuroendocrine tumor or locally recurrent tumor, along with liver metastatectomy. This was a representative image of a patient that was treated. And here again, you can see, again, they included all gastroenteropancreatic tumors. A majority of patients had actually midgut tumors, but there was a subset of patients who had foregut tumors. And patients had either major hepatectomy in conjunction with a resection and then additional ablation. And they found there was essentially one postoperative death after a pancreaticoduodenectomy and a right trisectionectomy. Postoperative complication occurred similar to the last study that I mentioned in 44% of patients, and only 11% of those were grade 3 or 4, primarily related with pancreatic resection, because I did just mention to you that small bowel primaries were also included in this subset of patients. And at a median follow-up of 56 months, there were 89 patients who experienced recurrence. 90% of those were confined to the liver. Their 5-year symptom-free survival and overall survival were 60% and 69%, suggesting that synchronous resection is feasible, again, in appropriately selected patients. So when should you consider resection of peanut liver metastases? Well, if patients have favorable tumor biology, that's not to say that patients with grade 3 well-differentiated neuroendocrine tumors should not be considered for resection, but certainly they should be done on a more selective basis. If the primary tumor is resected or resectable, we have inconclusive data regarding liver metastatectomy in the setting of unresectable peanuts. We have, again, it's all retrospective in nature. Most of these patients who were studied are small bowel neuroendocrine tumors, so you have to take that into consideration. The patient has to be fit and willing to consider a hepatic resection and understand that the risk of recurrence is actually quite high. In terms of fitness, you want to make sure they don't have carcinoid heart disease, and you want to make sure that you are able to resect at least 70%, arguably 90% for peanuts of the identified hepatic disease. Why consider surgery? Because we're surgeons. Because there is a potential for cure. There is a potential survival advantage. As previous colleagues have mentioned, it can help reset the clock. And it can be therapy sparing. We know that these patients live for a long time, and we don't know the optimal sequence of therapy. So sometimes surgery early on can allow for reservation of other treatment methods for down the line therapy. Thank you.